Good morning. I'm Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you for joining today's Kentucky SOS webinar presented by Mr. Van Ingram, Executive Director of the Kentucky Office of Drug Control Policy. All lines are muted. However, you can unmute your phone at the conclusion of the presentation to ask live questions for Mr. Ingram. You may also utilize the chat box for questions during his presentation. Mr. Van Ingram joined the Office of Drug Control Policy in November 2004, shortly after it was created with the mission of coordinating Kentucky's substance abuse efforts in enforcement, treatment, and prevention education. Mr. Ingram served with the Maysville, Kentucky Police Department for more than 23 years, the last 6 as Chief of Police. He has many accolades and awards and recognitions through his career. Mr. Ingram is a certified law enforcement instructor and has trained officers across the state on a variety of topics, including community-oriented policing, case management, and Kentucky substance abuse issues for chiefs, sheriffs, and command staff. He is a frequent speaker on a variety of substance abuse issues in both Kentucky and nationally. And Kentucky SOS welcomes guest speaker, Mr. Van Ingram.
Thank you, Emily. Good to be with you all today. A shout out to the Kentucky Hospital Association. We've been a really good partner with the state for many years now, and certainly with our opioid stewardship program has been a tremendous partner the last few years. Thanks to all of you all for what you do. I notice my wife is on this call. She is a nurse, and I won't say how long, let's just say it's been a number of years. So I always had some appreciation for what you do. But last year I got to spend about 5 nights in the hospital, and I got a whole new appreciation of what that's like, all the way from the maintenance staff and the cleaning staff to the food service, to the nurses, to the business office. It's quite an operation you all run, and seeing it up close and personal like that made me even that much more impressed. I want to talk to you a little bit today about the state's efforts in the opioid epidemic, some of which you're familiar with, some of which you may not be. If I'm not on my game today, I know some of you on this call and have heard me speak before. But if I'm not quite on my game today, I have a reason. We've been having some electrical issues at our house. And so I've, over the last week, have showered at Planet Fitness every morning. I know they tell you that it's a judgment-free zone, but I got to tell you, I've felt a little judged here lately there in the locker room at Planet Fitness. So that's part of my problem. And then the other problem is we don't have a stove. So learning to cook every meal on an electric skillet has been our charge the last week and a half. So not quite fully on my game yet, but we're going to get there. I'm going to try to share my screen here. Let's see if this is working. Yeah, I think it is. Emily, can you see my screen there?
Yes, I can.
Okay.
Yeah, maybe put it in slideshow so we just see your title page.
Van, we see the presentation side, like the speaker side.
How can I fix that?
Sometimes if you have dual screens, you can close out and choose the other screen. So if you're on screen 2, close out of share screen and go to screen 1, and then you'll have to start the presentation from there.
Well, I am not sure how to do that.
So close out of presentation in PowerPoint. And then choose share screen
Yeah.
and click on where your PowerPoint was. Because when you first shared screen, when we did the test, it was in presentation.
Oh, okay, hang on a second. I apologize, folks.
No problem. This happens more often than you think.
Yeah. You'd think after 2.5 years of this Zoom world, we would all have this all figured out, but no. So share screen.
Mhm.
Now what are you seeing?
Now I see your slides. Click, go to slideshow and start, and I believe it should pop up. Perfect. Thank you.
Okay. So let's talk a little bit about the opioid epidemic and the Kentucky strategy. We really hit this issue hard in 2012 with House Bill 1. House Bill 1 was called the Pill Mill Bill. It actually had about 14 chapters, and only one of them addressed pain clinics, but that's the name it got stuck with. Really what the bill was, we wanted to ensure that when an individual is being prescribed an opioid for a chronic pain, so we're going to be on them for a long time, that is a very measured and careful and deliberate decision between a practitioner and a patient. For too many years, it was a casual decision, and one that not enough thought, we believe, went into. Certainly, the pain clinics were an issue. At that time, there were 76 of them in Kentucky. Once we passed a law that kind of narrowed their focus and required them to accept third-party payers, required them to have a medical director on staff that had a background in pain medicine and some other things, about half of them packed up and left in the middle of the night, and we never saw them again because they weren't interested in good pain management. They were interested in something else. So that was a major piece of legislation. We became the first state in the country to require the checking of a prescription drug monitoring program, our CASPR system, before prescribing an opioid. Our Kentucky Board of Medical Licensure took that a step further and required it for any controlled substance. Since that time, about 30 some states have passed similar legislation, but we were the first to do that in 2012. In Senate Bill 192, a few years later, we came back with what was really a harm reduction bill. It had a Good Samaritan provision in it that allowed, if someone was in an overdose, if somebody else called 911 and stayed with the person, that they wouldn't be arrested if there were a small amount of drugs or paraphernalia present. It allowed for greater distribution of naloxone in that bill. But probably the most controversial thing it did was allow public health departments to operate a syringe service program. We have 75 syringe service programs in Kentucky, more than any other state in the country. I've been really, really proud of our public health departments and the work they have done. I have talked about it all over the country. People are surprised that Kentucky, a Southern conservative state, has syringe service programs and has so many of them, and they do so well. But that was probably the thing that's talked about the most from that session. We came back a few years later in Governor Bevin's administration with House Bill 333, limiting opioid prescriptions to 3 days for acute care. There's a great number of exceptions in that. The biggest one being if the prescriber just feels like 3 days is not enough, they could just document it in the patient's record why they didn't believe that 3 days work was not enough for that particular acute pain need. But really what we're trying to do there is reset expectations. Folks had gotten used to leaving after an acute care situation with 40, 50, 60 pills, and we were trying to reset those expectations with that bill. You know, after the Affordable Care Act passed and we started to have the Medicaid benefit, have a benefit for treatment within Medicaid for substance abuse treatment. Our focus was, we were able to change our focus. For years, we were trying to get people into treatment and increase treatment. But with that benefit, kind of if you build it, they will come. If you have a payer source, they'll come. And so we've really upped our game in this state about the availability of treatment. So we started removing some of the barriers. And one of the things we did this was with the Kentucky Call Center. One of the things that used to frustrate me is watching TV of an evening and see somebody with a lab scope, the stethoscope, talking about call their treatment hotline. When I knew those treatment hotlines were really just only applicable if you had a good insurance, if you had a third-party payer, and often they were paid under the table to steer patients toward a certain treatment center if they had a payer source. So this statewide line is run by Kentucky social workers. It's located in Prestonsburg, Kentucky. It's 8338 KY Help. They average about 400 calls a week inbound, and then they do outbound calls. So they do follow-up calls to the tune of another 1,000 of those a week. So they're very busy, and they've just put thousands of people connected with substance abuse treatment. And then our partners at University of Kentucky and the Kentucky Injury Prevention Research Center created the kind of the search engine that you would use to find a hotel room. You can use that same thing to find treatment. You can go in with a few clicks of a mouse and find out who has a residential program, who has an outpatient program, who has an intensive outpatient program near you. And you can see what kind of insurance or Medicaid that they accept. And just a lot of things that would take hours on the phone, you can now do with a few clicks of a mouse. And we've helped thousands of people get connected with treatment with that resource. We started working to centralize our naloxone distribution. As naloxone became more and more prevalent and more available, and agencies started to get money to do that, my agency was purchasing Narcan, public health was purchasing it, behavioral health was purchasing it. Now it all comes out of one place. We partnered with the Kentucky Pharmacists Association, and they take care of all the distribution. We just reimburse them, and they take care of all of it for us. And that way we can tell where it's going and more importantly, where it's not going. And so we can alter our efforts based on that. We've really, I've been blessed with some federal dollars, and we have a program called CORE, the Kentucky Opioid Response Effort, that sits in the Cabinet for Health and Family Service and the Division of Behavioral Health. The program is run by Dr. Katie Marks, just a tremendous young person that runs that program. And we've done a lot with that. And one of the things we said was that we came into money is we don't want anyone to be turned away that needs residential treatment because they don't have a payer source. Maybe they're eligible for Medicaid, but they've never signed up for it. Maybe they make just a little bit too much for Medicaid, but certainly they can't afford thousands of dollars for treatment. So we created the treatment stipend program. And the other thing the treatment stipend program does is we know that Medicaid often doesn't approve enough days stay. So we can keep people in the program up to 90 days with this money, because a lot of folks really need that time in a residential program. So just in fiscal year 21, that program, the treatment stipend program, served 12,477 individuals. And we're really proud to be able to do that. We work to expand our medications to treat opioid use disorder into FQHCs around the state. They've turned out to be really good partners, our federal qualified health centers, and very good at helping us expand the use of medications. We've offered free data waiver training through the core program. We've helped set up bridge clinics, that is clinics within hospital systems that when a person comes in with an overdose can immediately start them on a buprenorphine regimen so they don't go into withdrawal, and then serve as a bridge for a few days until that person can find a more permanent treatment situation. We've done that with University of Kentucky and University of Louisville, the St. Elizabeth Healthcare Center, some of the Appalachian regional hospitals in Eastern Kentucky, and always looking for more partners with that. We set up quick response teams that are served by often law enforcement, EMS, nurses, sometimes firefighters, that will respond to a person's home within a day or two of an overdose situation, a non-fatal overdose, and just provide them with resources and let them know that, you know, we know this event happened to you. We can help you get into a treatment and get into recovery. And we're really good work that's happened there. We've written an 1115 SUD waiver for corrections. Right now, we do provide some substance abuse treatment within our Department of Corrections, within our prison system. We've asked Medicaid, CMS to reimburse us for that. If we get awarded that waiver, we'll be the first state to get that. We feel good about our chances, and we're waiting on that final approval. If that happens, we'll be able to expand much more of our ability to have substance abuse treatment within the corrections and within the criminal justice system. The Kentucky State Police Angel Program started by then Commissioner Rick Sanders, but it's been continued. That program says, you know, if you go into any state police post and say, look, I've got an addiction issue, I need help, they will help you. If they have to put you in a state police cruiser and drive you halfway across the state, that's what they'll do. Over 200 people have taken advantage of that and walked into a KSP post and have been served by that program. A lot of people, you know, look to the police for answers, and that is example of that is this KSP Angel mission. We've done KYSOS law training. KYSOS law is a law that allows individuals to petition the court to force someone into treatment. It can be very effective. It has been very effective. But still a lot of people don't know about this law and what it can do, and we've supported trainings all around the state to do that. I mentioned our syringe service programs, and we're constantly looking to expand those. Thousands of Kentuckians have been steered into treatment because of their participation in a syringe service program. We've done Core 12 trainings around the state, especially in the criminal justice system. You know, Hazelton Betty Ford, the leader of abstinence-based treatment for many years, found with this opioid epidemic, medications like methadone and buprenorphine and as well as Vivitrol are often needed to attain any level of recovery. So the Core 12 training sets 3 paths. It explains to the patient, you can do an abstinence-only program, a traditional 12-step program. You can do a program with Vivitrol, a drug that blocks your opioid receptors, or you can go with methadone or buprenorphine, which is a partial antagonist, but also a partial agonist to the opioid receptor. And what we find when we give people that choice, even within the prison walls, like we do, it really balances out to about a third is how people choose, you know, how the choices go. So we think it's important to do patient-centered care and let the patient help decide what's the best move for them going forward. We've spent money, we've had what we call the Restore program, and we trained hundreds and hundreds of criminal justice professionals around the state on this method. We've offered 8 one-day trainings for the American Society of Addiction Medicine, ASAM, to get begin to work to be accredited by them. We started some other programs around that, helping people to stay in recovery. And one of the things we've realized, treatment's not enough. Sometimes people need help with housing. And the other thing they need problem with is a job. They need help with is a job. So we started something called the Strategic Initiative for Transformational Employment. About half of that program is paid for by my office, and about half is paid through CORE, the Kentucky Opioid Response Effort, the federal dollars. But we have set up around the state at each of our vocational career centers, there's 14 of them. We have one person that's only job is to focus on getting people in recovery linked to significant employment. A job that can has room for advancement, a job that they can support themselves on, if not immediately, eventually. Just in fiscal year 21, we served over 2,500 Kentuckians in this program and linked them with jobs, significant jobs, transformational jobs. Our partner in this is a program called EKSEP, East Kentucky Centralized Employment Program. And they've been a great partner for us. And we've been able to help a lot of Kentuckians in recovery find jobs. We've also partnered with the Kentucky Chambers Foundation. And what we've done there, you know, when Van Ingram goes in and talks to a business, yet I've been collecting a government paycheck my whole life, I probably don't have a lot of credibility, but the chamber does. The chamber represents business. And so they've trained over 5,000 business leaders in Kentucky on why they should allow for second chance employment, recovery employment, why people in recovery can make tremendous employees, and why that's the right thing to do, and why it's what we're going to have to do. We have 75,000 unfilled jobs in this state. And we need to get people back to work, and we need to get people in recovery back to work. We took that same approach with our Department of Corrections. And we started out with 5 probation and parole officers. We sent them to training to become job placement specialists. The federal government that funds that program liked it so much, they asked us to double it. We now have more than 10 Department of Corrections job placement specialists, and we've worked and placed hundreds and hundreds of people on probation and parole in jobs. We know that that's one of the keys to maintaining sobriety, to maintaining recovery, is meaningful work. And we spend a lot of time, effort, and money to link those things together. Housing is another big problem. A lot of times people come out of a residential treatment program and going back to the same environment they used to live in, where maybe their friends, maybe their family members, maybe their neighbors are still using. It's very difficult for them to go back into that same environment. So we've really been focused on supporting recovery housing. We've offered up grants for transitional housing to support MOUD. We saw that a number of our recovery housing around the state did not allow for persons that are taking medications for opioid use disorder to live there. So we've offered grant money for those that do and those that will, and have increased that significantly. We've added the Oxford House model. I believe we're over 60 Oxford houses around the state. This is a really good model where the residents kind of run the house by committee. And you have to have a job to work to live in an Oxford house, and it's a proven model that is nationwide and has worked really well. We've also offered up grants for sober living homes and grants to support traditional housing. We really want to focus on those and require that they follow the rules of the National Association for Recovery Housing, and really try to improve the quality of the recovery housing we have in the state. Peer supports, many of you may have peer supports in your hospitals and your emergency departments. We found them to be invaluable in this fight against opioid use disorder and this fight against addiction. We go back to that credibility issue. It's a lot easier when you're having a problem to talk to somebody who's had that same problem and have overcome it. It just seems more real coming from them. So we've really worked to increase the peer support specialists we have in this state. Another issue that we discovered was transportation is a huge issue in this state. So many people can't get to a treatment appointment, can't get to a job. So we started a program with the Department of Corrections where we use non-emergency medical transports from Medicaid. So we have contracts all around the state, every county, with folks to haul our Medicaid patients to an appointment when they have a transportation need. And we've done the same thing with probation and parolees. Now, right as we were starting that program, COVID hit. And so there wasn't quite as much use of the program as we would have liked. So we've expanded that to allow pretty much anyone within criminal justice, whether they're in the custody of the Department of Corrections or not, whether they're on probation, parole or not. So a lot of times when people are called on small charges, misdemeanor charges, possession charges, the judge will let them go into a treatment program, but they have a problem getting there. We've used these funds to get them there. And it's worked out really well and filled a tremendous void and a tremendous need. And we're going to be looking at how we can expand that program and continue to fund that into the next fiscal year. We don't want to forget about prevention. And we've spent significant dollars to get over 200 school systems to teach a program called Too Good for Drugs. It's an evidence-based program. It's proven to be very effective. And we're proud to be able to support that curriculum and pay for that curriculum in over 200 Kentucky schools. Sources of Strength, another program that's not substance abuse focused, but it's focused on ethics and good decisions. And it's a tremendous program. Young people really like it. And we're glad to pay for that as well. And then opioid stewardship, what you all know about. We've been really pleased with the way so many of Kentucky's hospitals have started their opioid stewardship programs, how they've done patient education, physician education support, community protection, and patient safety. All of that's so important, and we appreciate all the work that you all have done in that. So here's my contact information. I'm glad to speak with any of you at any time. I went through this kind of quickly so we can have some room for any questions or discussion, and I'll turn it over to Emily for that.
Thank you. Are there any questions for Van Ingram at this time? Feel free to unmute your line and ask directly or utilize the chat box for questions.
Here's a question. Would the Kentucky police cross state lines to deliver a patient to a treatment facility in Indiana?
I would doubt that. I think that would be a difficult thing for law enforcement to do. You know, what we've seen in Kentucky with our larger treatment providers, they have set up their own transportation networks. Some of our I can think of about 3 or 4 large providers that tell patients when they call, where are you? We'll come get you. And that could be in Indiana or that could be across the state. I've really been, they started that during COVID, at the beginning of COVID-19, but then they've continued it this whole time.
Okay, are there other questions? There is a question in the chat box, Van.
Yeah, let me pull that up. Thanks.
Okay. And then while you're reading that, maybe to the group, I am also going to input, type in your direct email if attendees have questions or want to learn more about these services and resources that you mentioned today.
Yeah, and the question's about fentanyl test strips. And it is a conversation about decriminalizing possession of these so patients can use them. We can distribute them through non-SSP programs like hospital pharmacies. Yes, the discussions are occurring. I'll be frank, that would require a change in the statute. When you bring in a controversial subject to the General Assembly, you may not always like what you get when it comes out the other side. So I would want to make sure we have the adequate support to pass that before we make that effort. We barely got SSPs, syringe service programs, passed in 2015. We barely got that over the line. And the federal dollars do allow public health departments to purchase and distribute fentanyl test strips, but under our current law, under the way you would read it, you could, a police officer could make the argument that it is drug paraphernalia. So it's a double-edged sword there. And it's something that we have had a lot of discussions about at the state level, but we're just not sure how to proceed because we don't want to mess up anything we do have that's working. I hope that answers your question.
This is Bob Desatel. I have a question for you. On the bridge clinics, I run a small 23-bed LTAC in Lexington, and we get a lot of the IV substance abuse cases in with endocarditis and abscesses and things. They usually need 6 to 8 weeks of IV antibiotics, and we can handle the medical side of things, but we really don't have the substance abuse counseling. And we've reached out to some different organizations about how do I get those services provided in our facility. And I guess the pushback I'm getting back is they don't know how to bill for services because everything is set up for outpatient and residential treatment programs and not for inpatient type utilization. So I don't know if your bridge clinics could help out with something like that or not. About a third of these patients leave against medical advice and then get readmitted later on and get heart valve replacements, et cetera. So these are the kind of the worst cases with severe medical problems. So we're trying to find ways to meet both their medical and their substance abuse needs.
Yeah, and that's really, so, as you know, as part of the disease process, I mean, more than 60% leave within the first 3 or 4 days of a residential stay. They sign out against medical advice and leave because they started to go in. A lot of them are in withdrawal, a myriad of other issues that causes folks to just to check out and go. If you and I could talk offline,
sure,
and we could get somebody from Medicaid on the line and talk a little bit about billing and how we might be able to address that.
Okay.
Let's go back to the chat. Board of Pharmacy will not allow us to dispense Narcan from our emergency department when obtained from the Department of Health from our retail pharmacy. Certainly, I'm willing to. That's another one. We probably ought to talk offline. Let me get more detail, and I'll talk to the director of the Board of Pharmacy. Larry Hadley's a friend, and his office is right above mine in the same building. So certainly willing to help you address that and see if Mr. Fink, if we can get any resolution there. Donna Davis asked, is there any activity to require long-term care facilities to be more flexible in accepting patients on Suboxone? I have to admit, I didn't know that was a problem. Donna, and if you want to send me an email and kind of give me some more information, we're happy to take a look at that as well.
Will do, thank you.
From a hospital discharge, that is an issue. Most nursing homes won't take patients on Suboxone or buprenorphine. I've heard different reasons of either prescribers, they don't have prescribers for it, and also that their pharmacies that they use for their nursing homes can't provide it. So,
well, I could certainly understand the prescriber issue. We have a limited number of buprenorphine or prescribers willing to prescribe buprenorphine. We have many who are data waived, but only just see very few patients, if any. So it's something we're continually fighting against and working towards, is increasing that. Now, as to not being able to stock it, that doesn't make a lot of sense to me. You should be able to order just like any other drug. I'm not sure about that, but I'll talk to some of my colleagues and we'll see what more we can learn about that. Jessica Johnson's talking about we have many patients that are not allowed MOUD access for residential placement, not just nursing homes. We have residential treatment facilities that don't allow it. And that's one of the nice things about Find Help Now, KY.org. When you can very easily find out. But if they're a Medicaid provider, or if they participate in any of our programs, they have to agree to be able to recommend medications for those that want them. And we make that part of anything that we provide any funding for. Any facility that accepts any of our funding has to offer medications. So if they're not, and they're funded, receiving any funding from us, please let us know. By us, I mean state government. Anybody else? If not, we might just give you a little bit of your day back.
Okay. Thank you. Thank you so much, Van, today for your time in this presentation. There are so many resources and services for our Kentucky's patients and their families regarding treatment and recovery. And I did put your your work email in the chat. So if for follow-up, or if anyone has direct questions, and Kentucky SOS will continue to partner with the Kentucky Office of Drug Control Policy and other state partners to continue to improve opioid stewardship in the state. Today's webinar slides and recordings will be posted on the SOS website, and I put the website address for your convenience in the chat box. I will also send it out to all project leads once they will be posted to the website, which will take about a week or so for that to happen. It looks like there was just another question or comment put into the chat box, Van. Yes, okay.
Yeah, we have the same issues with long-term IV patients accepted in our SB. What does SB stand for there? I'm not sure what swing beds.
Swing.
Okay. I should know about swing beds. Yeah, that is an issue for sure. There again, another access issue. I'm not sure, but if you could email me any information about that, the problems you're having, I could check with the right people and see what if anything is being done about it. But certainly we recognize there are barriers, significant barriers to medications, and we've spent a lot of time and a lot of money and a lot of effort trying to address as many of them as we can. But there are always places we could do better, that's for sure.
Okay, are there any additional comments or questions for Van Ingram at this time? And
please email me any issues you have. Always glad to collaborate and work on them and see if there's any way we can improve. Thank you, Dr.
Absolutely.
Stamp. It's always good to hear from you.
Okay, well, thank you so much for joining today's Kentucky SOS webinar. We look forward to continuing to work with your office and others to continue to improve opioid stewardship in our state. Everyone have a great day, and we will talk soon. Goodbye.